But thank you. Thank you. Thank you, everyone. This convening is recorded. We are very much happy to organize this convening right after ICASA. So it was nice seeing some of you in ICASA last week. As Florence has mentioned earlier, it is also almost the end of the week. So I hope we can get some time to have rest during the weekend. But then again, there is no rest for the wicked, and we are wicked. And when I say wicked, I mean it as super awesome. We are super awesome. We are wicked. We are wicked because we are driven. We are wicked because our fire comes from our lived experiences. We are wicked because we refuse to accept the systems that fail us, and that kind of passion and fire does not really let us rest. No. And instead of saying PLHIV community is resilient, maybe I'd like to say PLHIV community is wicked. Because when we say resilient, it means that something in the system is broken, something or someone is not doing their part. So when we say we are wicked, we are super awesome, we are focusing on ourselves. When we say we are resilient, we are focusing on the broken system, and we want to put the focus back on ourselves. In this integration process, we are putting our leadership up front and center, because if we are not in the integrated health program, then we will not be covered by universal health coverage. As you will learn later through the country case studies, we have seen PLHIV networks continue to stand, continue to adapt, and continue to lead, because PLHIV networks are wicked. They're super awesome. Since January, many of us have been carrying heavy news, from the US funding cuts to the global fund reprioritization. And this shifts has clearly impacted our programs, have impacted our networks, and have impacted our people. And many of us have been pushed into a space of fear, because there is shrinking budget, there is losing ground, fearing that we might be left behind. This global panic has conditioned our minds to be problem focused, because the problems have been so loud. So I hope in the next year, we can guard ourselves from the mindset that only sees crisis, because our movement has always been bigger than a crisis. Our communities need us to be solutions focused. We need to be solutions focused, and we need to ask what we can build, what can we protect, and what can we imagine each other. I'd like to borrow one line from the report, from the writer of the report. Her name is Edith, and she says that there is hope, but hope in itself is not a strategy. We need strategy, we need clarity, and we need each other. And so, to mark the Universal Health Coverage Day, we welcome everyone to the 17th PLHIV convening on the realities of integration. I have said a lot. I'd like to call on the GNP Plus Co-Executive Director, Florence Ruyako Anam, to set the scene of this convening. Florence.
Good morning, good afternoon, good day. I think this is really such a, I feel like it's a surreal moment. We came together in January. I think it was the last week of January, in a different mood. Many of us still reeling from the shock of the rapid funding decisions and our country's reorganizing shifts quickly. What was initially planned as a space to plan together around the global AIDS strategy that was going to be developed in 2026, and then prepare for the high-level meeting in 2025, and prepare for the high-level meeting in 2026, quickly turned into a space where we all came together to share what's going on in our countries, how are we engaging with whatever is going on, how can we support each other, and particularly how can we reinvigorate and reignite our leadership. And oh boy, have we not reignited the people living with HIV leadership this year. I can see us everywhere. I was excited when I asked Inad how many convenings have we had virtually this year, and this is our 17th. Thank you to everyone who has made it here. Every convening, we've been meeting every other 2 weeks. We share, we've learned from the convenings. We've been motivated at GNP Plus from the convening to further hold the People Living with HIV Leadership Summit in Nairobi in April. I believe a big, big, big moment in the HIV movement where people living with HIV decided we are not going to sit and cry anymore. We are going to lead, and we are going to tell you what works for us and how to move. We've come out of that convening with the agreement to come together and define what our people living with HIV requirements or asks for HIV services integration will be or look like, a report that we launched at World AIDS Day. And we are hoping that Dr. Patricia will be here to share with us some abridged version of that report. But coming out of that, we've seen different countries also do their own convenings. We've seen a very vibrant World AIDS Day, Candlelight Memorial, and all these other spaces you've invited us to. You've invited us to convenings with your government. I think it's been an incredible shift in the environment, in our leadership. I just want to pause and acknowledge that I see us ending the year in a different note. We started dark. There was no US. We did not know what we are doing. But as we look at certain things, I think there is signals of things to be hopeful and optimistic about as we go into next year. The Global Fund replenishment, though many other regions and countries haven't pledged, but we saw a significant contribution from the US. That's a signal. We are seeing our governments going into government-to-government conversations with the United States and signing MOUs right now. There's a lot of also unknowns in that MOU, but there's a signal. There's an opportunity for engaging with our governments, as we have done this year, to continue in the implementation of whatever adaptations will happen next year. So where we started with no US, no funding, we have signals. And I think I want to be optimistic, as the raging optimist that I am, and hope that this motivates you to feel proud of the work that you have done in the whole year. I just want to say thank you to everyone as we start, and to also say you have motivated us to move from a space of learning to an initiative we are calling People Living with HIV Leaders Now. And it's been vibrant. It's been vibrant in our leadership. And I will tell you why we believe so, Bongile and I, my co-executive director. As the changes happen in the HIV response, two critical players are important here. One, it's our governments, because they will fund, change policies or adapt them, change health facilities or adapt them, ensure they serve human resources for health, train them, organize the facility for us to come in there. Whatever it is they will do. And then there's us who have to come to that facility. And we have to know, and we will experience things firsthand, where it pinches, where it's working, where we feel it could go differently. And we have to be able to inform on what's working, what's not working, what could improve as these changes and adaptations are going on. We are in a season of change. We have engaged so far with our governments, and we continue to do so. And I hope we can continue in the same manner to do so and engage with leaders like UNAIDS and WHO and Global Fund to ensure that every player that is making decisions in the HIV response is informed by our lived realities. That's the end of my preaching, which I like to do because I'm asked to set the scene. I would love to say that we are excited today to welcome Anjali Atreka, the Deputy Executive Director from UNAIDS. We have been holding this meeting and we have been joined severally by different partners, but no one at this level of leadership. So we are really, really, really honored to have you here, Anjali, and really excited that you would be able to come and speak to us and stay on as much as your time allows to listen to what our requirements for integration are and what the countries are also sharing. I also want to, before Anjali speaks, let you know that a companion to the integration report will be released tomorrow. It's a country case studies of 6 countries. Some of the country leaders interviewed will speak today. And those who you will not hear from today, please make sure to watch out on our socials. Tomorrow, on the marking of universal health coverage, we will release these case studies. Inad and I have read it. It's been written by the incredible Edith Magak. It's kept to our tone and our message, and it it captures the realities on resources, implementation, and policies for integration at country levels from the viewpoint of people living with HIV national network leaders. I am grateful for the opportunity to be here with you all and looking forward to learning and sharing. Thank you, and back to you, Inad. Sorry, I welcome Anjali. Please give us your opening remarks. Thank you.
Thank you so much, Florence. First, I have to say, your optimism, your leadership is extraordinary, and we are with you, and we do see these positive signals, as you noted. We are ending the year with these positive notes, and I think we have a lot to look forward to as we approach 2026. So thank you, Florence. Thank you, Sibongile, Inad, and the entire GNP Plus team for your leadership, for convening this important discussion. And congratulations again on the launch of the PLHIV Minimum Requirements for HIV service integration. We are thrilled about this report and really, really looking forward to the case studies, Florence, that you mentioned that will be coming out. I am just coming back from seeing so many of you at ICASA, and it was incredible to hear your voices, people living with HIV, other communities, and all your diversity. You continue to show, I won't say remarkable resilience, but remarkable wickedness, as Anad said, working together and supporting each other, working with governments and other stakeholders to continue to transform the AIDS response. While it's been a tough year, we all have shifted and have to focus on the future and how we make the best of the future that is in front of us. So again, good morning, good afternoon to everyone that's joined from around the world. It's a pleasure to be with you all, community champions of the HIV response, partners, allies, and to be part of this important discussion on the eve of Universal Health Coverage Day. And just after World AIDS Day, which we commemorated, it's hard to believe it was last week because it feels like so much has happened since then. But thank you for inviting me to join this important discussion. Together, the UN, governments, policymakers, service providers, and most importantly, communities of people living with HIV reflect on how integration can strengthen, not weaken, the HIV response, and how, for that to happen, people living with HIV must remain at the very center of this transformation. Today's webinar focuses on an issue that has become urgent for communities everywhere: the realities of integrating HIV services into primary health care and broader systems for health, and what this shift means for people living with HIV, for PLHIV networks, for communities at large, and for the future of the HIV response. First, I want to recognize the importance of the new GMP Plus World AIDS Day report on minimum requirements for HIV service integration. Your report is powerful because it does what our movement has always done best. It centers the lived realities of people living with HIV. More than 1,800 PLHIV voices, together with the national and regional networks, have defined what safe, effective, person-centered integration must look like. This report reminds us that integration cannot be an academic exercise. It must be built on the rights, the fears, the aspirations, and expertise of the people who lead the HIV response and who also depend on these services. These minimum requirements for participation, equity, stigma-free care, strong systems, and shared leadership from governments and communities offer a true blueprint grounded in people's needs and the power of communities. Second, as we mark UHC Day, let's be clear: universal health coverage is not optional for ending AIDS. Reaching UHC is essential if we are to sustain uninterrupted access to high-quality HIV treatment and care, accessible and people-friendly HIV testing, tailored HIV prevention, including PrEP and combination PrEP, mental health support and care, and integrated services for other comorbidities and for aging with HIV. We cannot end AIDS without strengthening both health and community systems and without closing the gaps in primary health care, financing, and equitable access. UHC is the vehicle through which HIV services become resilient to political change, funding volatility, and external shocks, and the pathway to addressing people's health needs across the life course. But UHC will only accelerate progress if PLHIV leadership, HIV-focused services and systems, and community-led models are not diluted in the process of integration, but really become the anchor in the process of integration. And third, and this was mentioned, the new global AIDS strategy for 2026 to 2031, which we're privileged to have been developing together with all of you. We will be discussing and approving this strategy at our board meeting next week. And again, I want to thank so many of you on the call today and among your networks who have inputted into the strategy. The strategy offers an important vision. It recognizes integration not as a cost measure, but rather a means to strengthen and sustain person-centered HIV services, grounded in human rights, grounded in gender equality, and grounded in community leadership. The strategy calls for integrating HIV services with primary healthcare, where it improves access and sustainability. It calls for protecting tailored services for PLHIV across the life course, key populations, and adolescents. Integrating HIV with non-communicable diseases, cervical and anal cancers, mental health, SRHR, TB, viral hepatitis, and STIs. Now with the global targets for 2030, for the first time, all of this integration is incorporated. Integrating community systems into broader health systems and sustaining community-led responses is also deep within the strategy and a core component of national systems. The strategy clearly states integration must build on, not replace, the strengths of the HIV response. That means keeping dignity, rights, and community leadership at the center and ensuring sustainability of the gains in the HIV response that we have achieved collectively. Finally, what's the role of global health institutions like UNAIDS in this transition? Our responsibility is to ensure that as HIV services are integrated in diverse and country-specific ways, that PLHIV networks do not lose visibility, resources, or authority. Integration cannot become invisibilization. This means institutionalizing PLHIV leadership in national decision-making, planning, and accountability mechanisms. It means securing domestic and international funding for PLHIV-led services, treatment literacy, community-led monitoring, peer support and advocacy. It means ensuring long-acting treatments, diagnostics, and prevention tools remain accessible within UHC benefit packages. It means standing firm against stigma, discrimination, and criminalization that impact services from being reached by PLHIV. It means supporting countries to implement and scale up integration models that are equitable, focused on service quality, context-specific, and grounded in evidence from communities. As global institutions, we must use our political and normative authority to make sure integration strengthens, not weakens, the HIV response. We must also help countries anticipate and address the risks of integration, track outcomes and impact, and ensure accountability and quality. Most importantly, we must ensure that integrated related discussions, planning, financing, policymaking, and monitoring happens with active engagement of PLHIV networks and other communities. We owe this to over 40 million PLHIV who built this movement and continue to hold the systems accountable every day. I really want to just close by ultimately just thanking you. Today's conversation is a critical one. The realities on the ground, from clinic closures to stockouts, from anxiety in the communities to shrinking civil society space. We know that we need to continue to work together so that we can protect those hard-won gains. UNAIDS is indebted to GNP Plus and to every PLHIV network represented here and across the globe for continuing to lead with clarity, with courage, and with an unwavering insistence that nothing for us can be done without us. Thank you again, and I look forward to hearing today's discussion.
Thank you so much, Anjali. Round of applause. Thank you for the inspiration and the encouragement. Thank you for highlighting that UHC is the vehicle, the pathway to address our needs. And UHC can only be achieved if we, the people living with HIV, and our leadership are not diluted, are not invisibilized, but as anchors in the process. Thank you so much for those powerful and inspiring words. We are going to open reflections or questions to Anjali. If you have one, please feel free. There's someone in the chat, Simon. Hi, Simon, saying that we also need to ensure to recognize the resilience and leadership of key and priority communities, especially in the face of challenges such as restricted civic spaces, the rise of the anti-rights, anti-gender movements, human rights violations, criminalization, and funding constraints. Thank you so much, Simon. Do we have any questions? Feel free. Okay. Before we proceed, I'd like to call my colleague Helena to facilitate a last screenshot for the year. We would like to take our photos together. Helena.
Yes, Enad, thank you so much. I would like to ask for all the panelists to please switch on their cameras so I can, yeah.
Can we see the participants?
Unfortunately, on the participant, no, only the page of the panelist.
Oh, sorry, participants. Only the panelists.
Nelson, Flavia.
Tariq.
Yeah, Tariq, Flavia, Nelson, if you could kindly put on your grade.
Yeah, I'm here.
Okay, good. I'm on.
Thank you.
Okay, so I'm going to count 1, 2, 3. Give me your best smile. Thank you, Tari. Thank you.
You want
Okay.
us to smile? You want us to smile with disruptions? Thank you. Anyway,
We need to remain positive, eh?
We have to be wicked.
Yeah, we
Super
need to
awesome.
remain positive also. Thank you. Over to you, Inad.
Thank you. Apologies to the participants. I thought we were getting the pictures of all. But moving forward, we are very happy to share that we have successfully launched our report, as Florence has mentioned, last week at ICASA. But since some of us were not there, we would like to invite Dr. Patricia Maritim to share the findings of the research, with everyone. Dr. Patricia, I'll share the screen for you, okay?
All right. Hi, everyone. Thank you for inviting us into your space. So I'll be sharing about the work we did on behalf of GNP Plus with my colleague, Dr. Mumbi Chola. You can go to the next slide. So as you are all aware, there's been significant progress that has been achieved in the global HIV response, as evidenced by a decrease in new infection and a reduction in AIDS-related deaths. However, progress to achieving global AIDS targets have been compromised with funding cuts to the HIV response, which has not only exposed the fragility of the response itself, but threatens the sustainability of the progress that has been made. So as countries are grappling with with these shifts that have happened, a number of mitigation measures have been proposed, including heightened domestic resource mobilization and integration. So integration is a measure that is aimed at promoting a more sustainable response, but for it to be effective and to live up to its potential and its benefits, there's a requirement for us to be strategic in how we adopt it for local country realities, to ensure that it maximizes existing resources and infrastructure, while ensuring that throughout integration processes, people living with HIV at all levels are involved in decision making. Next slide. So this report sought out to address three main study objectives. So first, we sought to identify what the minimum requirements are needed for responsive integrated HIV services at primary healthcare and community levels that can ensure sustained access to treatment and other aspects of HIV care. We also sought to explore and understand the role that people living with HIV networks can play in the integration of HIV services, particularly within community levels, which can ensure that services are delivered as close to the household as possible. And finally, we sought to solidify the leadership embodied by people living with HIV by outlining what roles networks and service providers can play in ensuring that the delivery of integrated services is person-centered. To do this, next slide, we used a mixed methods approach. So we collected data through qualitative interviews with networks of people living with HIV, and also organizations that are the fore of conceptualizing what integration looks like for HIV care, as well as a survey with people living with HIV from across the globe. And we were able to get responses from over 1,800 participants from Africa, Southeast Asia, Europe, and other regions of the world. Next slide. So in terms of who we were able to reach, a majority of the people living with HIV who took part in the survey were from Africa. Slightly more than a third of them were aged between 25 and 34. More than half of the participants were women, and the largest proportion of key populations who took part in the survey were men who have sex with men. So we kind of tried to map what the common access points for services are, given the funding shifts, and public hospitals still remain the most common facility type for where people are accessing care, with the HIV clinic still being the most common access. We found that people are still accessing care regularly, women and non-binary participants. Next slide. In terms of gender, we found that across all genders, so men, women, non-binary participants, there was an increase in ART service provision and TB screening services. However, across all genders, there was a reduction in mental health support services, and women in particular reported a decline in cervical cancer screening and maternal and child health services in response to the funding cuts. Next slide. Now, in terms of age, what we feel more unchanged across all age groups, pre and post the funding cuts. But there were slight variations for particular services. So there are services you would see where younger people or people who are older reported an increase in some of the services like ART provision, while younger or older participants reported decreases in other services like mental health services. Next slide. So through the interviews with the key informants and the people living with HIV network leaders, we try to describe what the funding cuts have done in terms of the networks and the work that they're doing, and overall just what impact it's had on the delivery of person-centered care. So we map this in terms of identifying whether there'd been changes, whether there's been stuff that's been scaled down, or whether it had direct impacts on the lives of people living with HIV. So some of the changes that we were able to see were the introduction of new policies and structures. So this would look like the development of national standards, of briefs, of communiques, which highlighted the values of integration and tried to identify some of the essential elements that are required for integration models to be successful. Further, there was also increased engagement with state actors in countries like Uganda, which resulted in increased budgetary allocations towards health and HIV. And in some countries, there was also introduction of user fees, which could have been catastrophic to people living with HIV. A very sad outcome of the shifts in the global health funding landscape was the closure of some people living with HIV networks and support groups, and also instances of stigma and discrimination, and generally a decline in the quality of care because networks had to scale down their activities, so they're not actively involved in implementation, not actively involved in monitoring and evaluation, which meant that there was the reflection of the lived realities of people living with HIV in how care is being provided declined. Next slide. Another shift that was observed by the people living with HIV networks was restructuring of activities and services, where networks had to repurpose existing resources to meet the new moment and see where their services were needed the most, while also exploring other opportunities for resource generation so that they could be able to continue with their activities through avenues such as social enterprises and social contracting. Then we also identified that there was increased reporting of distress, whether it's depression, anxiety, that was associated with the funding cuts, a lack of clear communication of what these funding cuts meant to people living with HIV and their capacity to access care, where to access care from, and also just fears around what would happen in terms of their health and well-being. Further, the introduction of the user fees was also placed burden on households, which typically might have lower socioeconomic resources and had to prioritize where they would spend their resources. So drawing on this kind of idea of what's happening in terms of service provision and what impacts these funding cuts had, we sought to define some minimum requirements that should shape future directions towards integration. Next slide. So we identified 7 minimum asks that we think are essential for at global, at national, at community, at primary care level when we are thinking about integration and what needs to be included. So first, in response to the fact that historically a lot of the involvement of people living with HIV and their networks has taken a more tokenistic approach, we call for the institutionalization of plans to engage people living with HIV networks in any moves towards integration. This will ensure that the voices and the lived realities of people living with HIV are incorporated in governance frameworks, are incorporated in the development of any policies, of plans, of integration models that are going to be, rolled out in communities. A second ask is that integration should be clearly defined. So one of the challenges that we found in the discussions with the network leaders is that there's so many different definitions of integration that shifts according to context. So countries should be able to have a clear definition of integration a definition that should be shaped not just by health actors, but also by health actors outside of the health field. Because if we are to think about integration, we are thinking about people living with HIV holistically and recognizing that health needs are not the only needs that people living with HIV have. They might have other social needs, and creating a definition of integration that recognizes one's holistic needs is crucial, even as we're thinking about what integrated models ought to look like. In addition, a third minimum ask that we're calling for is for the importance of recognizing that people living with HIV are diverse, right? Whether it's through gender, whether it's through migration status, whether it's through sexual orientation, gender diversity, age, right? Any integrated response needs to recognize that and make sure that as we're designing processes, as we're thinking about the models, that health equity should be at the center of any of the integrated approaches that we have. Next slide. A fourth ask is that the design and the delivery of integrated models needs to be comprehensive. So beyond the focus of providing treatment, it should account for all aspects within the HIV care continuum, both within facilities and community settings. These integrated models should also be able to account for health needs alongside other HIV health needs alongside other health needs. So whether that looks like NCDs, whether it looks like mental health support, it should be able to view a person living with HIV holistically and provide them also with social support. So this could look like linkages to social protection programs, to economic and livelihood programs, just to ensure that all a person's needs who are coming into contact with the health system are able to address whatever needs they have. A fifth ask is that for integration to be a success, we need to create a system, resilient health system that are able to rise up and meet this challenge of, what does integrated healthcare mean? So this means thinking about what data systems we have, thinking about what laboratory systems we have, thinking about cost. How do we make sure that care is affordable? I think if this moment has taught us anything is that if we don't keep our eye on making sure the different health systems building blocks are adequately supported, then we're not going to be able to successfully integrate HIV into primary care community health systems. Next slide. Our sixth minimum ask was that integrated services should be stigma and discrimination free. So not only is integration calling for move outside of the facility, it's also bringing in a new cadre of healthcare providers, of community volunteers who might not be well versed with what essential considerations for creating a judgment-free and non-discriminatory environment that ensures that people living with HIV feel as though they can continue seeking care. So it's important for all integration models, all integrated services to not only maintain the privacy and confidentiality of those accessing care, but to make sure that environments in which people living with HIV are coming into a normative feeling, it's embedded in the ethics of the environment that they should be non-discriminatory. Ask was that governments must take the responsibility to purchase HIV treatment, right? And to also create an environment investing in new technologies that are necessary, new technologies, new innovations that are necessary for maintaining the health and the well-being of people living with HIV. Next slide. So as our final objective was also to map out what roles people living with HIV networks play, the challenges they face, and what roles they can play going forward. So some of the key roles that networks are playing is in providing peer counseling, is for advocating for the needs of people living with HIV and reflecting that in national decision-making bodies. They are also actively involved in treatment literacy and conducting home visits. So key challenges that networks are facing include limited funding and financial support. They face stigma and discrimination, as well as difficulties in meaningful engagement with governments. That is also associated with kind of some of this resource challenges. Next slide. So as recommendations for the role that people living with HIV networks can play going forward in ensuring that the HIV response centers integration, and integration is at the core, we identified some areas where we felt that focus need to be placed. So the key of which is still within the realm of leadership and governance for equitable, accessible, integrated HIV services. So here we emphasize that people living with HIV are key. They're the most important pillar in any integrated HIV response. And networks should form deliberate plans on how to make sure that they're engaging with state actors, make sure they're engaging with other implementation partners to ensure that the lived realities, the voices of everyday people living with HIV are reflected in policies and plans, in how we are reorienting our health systems to be able to meet this moment of changing funding. Further, people living with HIV networks have and continue to play a really significant role in advocacy for comprehensive integrated services. And this could also go on to these minimum requirements at country level, right? And the networks themselves can strategically collaborate with governments and partners to ensure that integration is not just in nice policy documents, and that intention is carried out and trickles down into communities. One of the biggest challenges we identified was in a lot of communities, integration is still something that is high level. So networks can go into communities and talk to people living with HIV, with their families, with their communities, and kind of talk about what integration is, what is expected to change, and how, and still emphasize that, accessing care through primary healthcare facilities within communities is still an opportunity for receiving high quality HIV care. So leaning into the work that they can do in terms of community preparedness to make sure that people are ready for integration. Further, people living with HIV networks are already involved with implementation, so they can keep, working on demand creation, in identifying new people living with HIV, in doing testing. However, so far there's been limited direct investment into the work that people living with HIV networks are doing. So that's a point of advocacy and a point of call to partners and governments to make sure that they actually invest through platforms such as social contracting. Then finally, we can make all these claims of pushing for integration and putting measures that are aimed at meeting the goal of integration. But it's essential that even as we're putting these measures, we think about monitoring and evaluation that captures the experience of people living with HIV. And this could be through what you're already doing in terms of community-led monitoring, but also things like user satisfaction surveys, things like user preference methods. So opportunities for us to really make sure that integrated services are aligned to the needs and the requirements of people living with HIV. So in conclusion, it's people living with HIV and people living with HIV networks are a critical part of the HIV response. So these are some of the considerations that you could make as you're advocating for integrated services within your countries, within your communities. Thank you very much.
Thank you so much, Dr. Patricia. And we will be sharing the slides with the registered participants. We will also be sharing the recorded video of this convening. It will be in our YouTube channel. So like and subscribe to our YouTube channel. Thank you so much. There is a question though for Angeli in the chat. I think this question came in just after Dr. Patricia started their presentation. So the question to Angeli from Julius, I'm just wondering if there is an aspect of productivity among the persons living with HIV in the broader context of social and economic productivity as people age with HIV. So he's asking about this in the new strategy of 2026 to 2030. Sorry, yeah, we are noting down your question, Julius, and we will send this to Angeli. I don't think Angeli is still here, but moving on. Thank you so much, Dr. Patricia, for those points. Thank you for emphasizing the minimum ask of integration. We hope that the PLHIV, the wicked and awesome PLHIV networks and leaders here can use these points in their advocacy at the country level. But moving forward, we will now hear the different country studies or cases, the different country level experiences of integration. What has been the progress? What are the challenges? As Florence has mentioned, we have conducted a case study scoping of what are the country level experiences or realities of integration. So we have colleagues from Uganda, from Kenya, from Indonesia, and from Morocco. But for now, we are going to start with Uganda. Flavia, are you there?
Yes, thank you very much, Inad. I'm on call, and I'm glad to be here. And for all the viewers and the team at GNP Plus, and of course the keynote from UNAIDS, we appreciate. Yeah. So for me, I'll just start. You're asking about the opportunities and challenges, the challenges that we have faced over the years. I think for us, I'm not going to start on the negatives because they have already been laid out in the study. The disruptions are very clear and we have had a lot of emotional distress, but I don't want to dwell on that. I want to say the opportunity was that as a people in the HIV network, we are grounded. We are the public service that is not recognized by the government, that is not paid, that is not counted. Because when you look at when the disruptions came, it is the very communities of people living with HIV who were first to feel the brunt. Because in Uganda alone, about 8,400 community members of people living with HIV, a majority who were doing expert patient work, mental mother work, were laid off. And therefore, this meant that the work we've been doing over the last 30 years, and remember, so I'm somewhere, I just got a little bit of distraction, but I was telling people to keep quiet. So I'm saying that as a country and as a people living with HIV, we have community systems that have stood the test of time. Over 30 years presence at national, at sub-county, at parish, at community through support groups, but also working in the facilities and in the social services community level. And we have continued to emphasize that even when the disruptions came, we are not going to relent, because relent is not our creed. Our creed is that we must live and live to the future. So if we relent, If we lose hope, then the entire community we are leading, for which we show that we are models, is likely to also fail to access services, fail to continue to prevent transmission to the loved ones. And here we are. The other opportunity was that we are working with the Ministry of Health and working with Uganda AIDS Commission. And in fact, for example, the National Forum of People Living with HIV, having had a dilapidated building that we could not host, the Uganda AIDS Commission gave us a seat. So we sit at the Uganda AIDS Commission. For us, that is an opportunity. And right from the word go, when the disruptions happened, we even had joint petitions to Parliament with Uganda AIDS Commission, with Ministry of Health, and with civil society. We went to various committees of Parliament and we petitioned. And guess what? In April, March, the president allocated a supplementary of about $200,000 to fill the gap. And for us, that is a commitment and an opportunity that we needed to take advantage of the political will. As a country, we have a political will. We don't deny that there are gaps, but I think for me that was a gesture of consideration, and we were assured by government that the medication would not cease. It has not ceased, but we had several interruptions. And with the interruptions, we were quick to engage the Ministry of Health through the pharmacy department. And we kept asking, where is PLHIV-led? Where is the third and fourth line? And indeed, they were brought, and we have been taking them and ensuring that our members continue to survive. I'm not saying there is no gap. There are gaps. But I choose to be positive. And from that moment when the cuts happened, we as a National Forum, we started a weekly WhatsApp call because we didn't have resources to monitor. We didn't have resources to follow up on the 135 districts, the 18 national networks, and the 10 cities to see what's going on. In the first instance, we made calls, live calls, and we heard what was happening in the calls. Have become our M&E process, that every week we hear from what is going on in the community, what the government is doing, what the civil society is doing. And it is something that we look forward to every week from February. This is a very strong communion. And we also added on quarterly engagements with our district networks and partners. And we have had some partners coming to say, okay, there is no money, but let us support some of your districts with communication money. We had UNAIDS come in light of the psychosocial support, the mental distress. They gave us some support to run a helpline, to reactivate our helpline, which is working. It is looking at mother-to-child transmission, looking at mothers and babies. We've been following up from the region, and we think, there are opportunities. We cannot be crying. We continue to talk to the ministry. In fact, we at one time, when the integration policy and technical working groups and task forces were being made, the communities were left out. And we wrote to the ministry, to the PS, to say, you cannot do integration that is targeting people with HIV and you leave us out. And we were glad that on the HIPAC, we had representatives of people with HIV and communities who were co-opted to the HIV integration, health integration advisory committee. But some of us were also co-opted on the HIV integration task force that had started way back in February, in January, and we were not even a part. We didn't know what was going on, but they brought us on. We were part of the developing of the preliminary training materials. At first, we didn't go for support supervision, but slowly they are encouraging us and they are inviting us to participate. Of course, it's not sufficient, it's tokenistic, but it's a beginning for us to keep talking from within. So in our country, they say you can complain when you have little. From the little you have, you continue complaining and you get additional. The other opportunities that the Ministry of Health and TASO, our IPR2, is currently conducting a mapping of CBOs and CSOs. And all of us who are on call, I want to let you know that the majority of community-based organizations and individuals who are in facilities and communities serving are the people living with HIV support groups and expert patients. So like I said, we are static, we are immobile, we are there, we are trusted, and we cannot be wished away. And I keep saying integration should not disintegrate us. And so we are part of the community work. Members are volunteering to support others. We are ensuring that our partners are getting the treatment. They are trying to adhere. Of course, also, to let you know, is that in Uganda we have 1.5 million people, but 1.3 are the ones on treatment. But we also know as of last year, 200,000 are lost to follow up. We don't know what this year will increase or how much it will be. But we also have had 55,000 who are non-suppressed. And we know that as of March, we had an increment from 55,000 to 60,000. So our role now, we have asked, the government did not have deliberate intervention for community health integration. So as a community, we have, as the NAFOFANU and members who have said, we must have an integrated community health campaign. And we have started. We have started with 40 districts. We are going to look for the recipients of care. We are looking for the vulnerable communities to understand what this integration is, the benefits, the challenges. But we are also asking where it doesn't work, for those who have a face to lose, for the adolescent girls and young women, for the key populations, for the older, for the people with disabilities, can we have differentiated service delivery reinstated? So we are continuing to engage also with the AIDS Commission to work on the HIV response sustainability framework, and we have already made sure that some funding is available, that when it is actualized, government will give directly support to the communities. But we are also hopeful that when government, after signing the different MOUs and grant agreements with different countries, they are going to be financing communities directly, because we are the public service which is not recognized in the books, but which is doing work that government cannot survive without. And we are saying where they are brought CHUs and VHTs, they are good, but they cannot drive the HIV response, mobilize communities, bring people to access care like us, as we are driven by our lived experience. We are driven by the passion because we know what it means, where we have come from, and we can't afford to see another baby being born with HIV. And so we are continuing to claim space on different advocacy forums, and we are trying to engage as communities in solidarity to ensure that as we do our work, we are also integrated, but also drum the beat about financing for community systems, strengthening not only for program work, but that we need money for core support for infrastructure. We cannot continue to do work in air and to depend on donors when we have a government that has oil, a government that has got minerals, a government that has got resources like us, who have been here supporting communities, and then we are left to be erased. We refuse to be erased, and we continue to say we are here immobile, static, and trusted, and that our systems cannot be done away with because of the funding cuts, because of integration, because of reprogramming. We are saying we are here to stay. We are still strong. We are going to work in solidarity at national, at local, and at global level to ensure that we continue to exist. And we are not going to be cowed down to say, don't say you are people living with HIV. We are 1.5 million Ugandans. We cannot be cowed to denounce our name. And the name is a belonging. We cannot choose another sense of belonging right now. And I want to say we need more investment in creation of awareness for the communities of HIV. We need to continue to do our treatment literacy, to continue to support our members to access services, continue to support each other with psychological, mental support, because it has been very painful this year. And we must see that we work closely with government within the systems and structures, because if we are aside, we'll continue to be left out. We don't want to be invisible. We want to continue to be counted, because when we are counted and visible, then investment will come. And that's why we are saying we are here to stay. We are immobile. We are static. We live with HIV, and we are proud to say we are at the fore of the HIV response because we are, and that is why the HIV response exists. And therefore, whoever is working on HIV cannot leave us behind. No one can be left behind. No one can leave us behind, because they are, because we are, and we are because they are. So whatever, whether it is research, whether it is education, whether it is programming, whatever it is, we must be at the center of anything to do with HIV.
Oh, she dropped off. Is, is Flavia here? No, she dropped off. Oh, that was a passionate.
I want to say
Flavia,
that I am still here and I'm not
Yes.
gone.
Okay,
We
no,
can't be
the other
raised.
one.
Over to you, Inad. Thank you so much.
Thank you. Thank you so much,
Thank
Flavia.
you,
That was
thank
a
you, thank you.
very passionate and very wickedly powerful intervention. And thank you for sharing with us the challenges and the realities of integration in Uganda. We have noted them down, and thank you also for sharing the opportunities. Now, from Uganda, we're flying to Indonesia, and I hope we will not have jet lag because that's a long flight. But from Uganda, we're flying now to Indonesia. So we have Merinda Sebayang from Jaringan Indonesia Positive, or JP. Me, in Indonesia, can you share what are the challenges in your advocacy for integration, and what do you think are the critical strategies for the sustainability of PLHIV-led responses?
Okay, thank you so much, Inat. And first of all, thank you so much, everyone. Thank you, GNP Plus and team, and also Dr. Patricia for the great presentation. First of all, I'm also very grateful because in the last 2 months, I've been part of the HIV Joint Program Review as a national reviewer. So I can grab a lot of information during the review processes. So I will start with the epidemic situation in Indonesia. So from the review, we identified that new infections in Indonesia have decreased by about 49%, but also it's still high number because our new infection for, I think, per September 2025 is around 25,000 per year. And then we also understand that prevention success was seen in the people who use people with injecting drugs and sex worker groups. And also AIDS-related deaths have begun to decline since 2021, but remain 59 up to 60% higher than in 2010. And MSM group remains the only group with long-term increases and now account for the largest proportion of new infections. That's the epidemic situations. And also, for the last 95, the viral suppression rate in Indonesia for people living with HIV undergoing testing is 94 up to 95%. Of course, this is indicating a high quality of treatment when services are successfully accessed. However, despite progress in the cascade, its achievement also still inadequate to address changing transmission patterns and epidemic determinants. But on the other side also, among children, only 42% know their HIV status, and children have the lowest viral suppression rates among age groups. So we still have a lot of challenge according to our national cascade performance. And then related to ERV, we also, as people living with HIV in Indonesia, we are grateful because our government has commitment to support ERV under the national budget. So our government already allocated for 2026 for the treatment of antiretroviral is for the around 400,000 people living with HIV. We're providing ERV for the next 2026. However, from the review process also, we identified that proportion start ERV is at stages 3 and 4. So we know there's gaps in upstream testing and linkage are still significant because many new people living with HIV are diagnosed at an advanced stage before ERV can be started. So, so the number of people starting ERV continues to increase. However, it has not been followed by improved early detection, meaning that increasing ERV does not automatically mean success in finding case earlier. And we identified 3 determinants driving gaps in the service change. First, about health system and geographic barriers. Especially in our eastern part of Indonesia, we have a challenge about the distance between location of health facilities treatment availability and security issues. So it has led to chronic failures in service connectivity, retention, and viral load monitoring. And also, we identify vulnerability of key populations and also other vulnerable population. Children were the group with the weakest cascade performance at each stage. Women face gender-based barriers in accessing services. Adolescent and young adults saw lower rates of screening and also viral load suppression. And we also identify our social and structural barriers. Stigma still exists in the main clinical determinants. From our IBBS 2023, we identify that people living with HIV who perceive stigma, it has chance 20 times chance more low for viral suppression. And also in the social and structural barriers, we identify fear of negative judgment and breach of confidentiality in health facilities, drive service avoidance, which is a strong predictor of failure at every stage of the HIV service cascade. And we also, in the financing landscape, we identify achievement and risk. So the first risk, we have a gap in prevention or in the logistic for the prevention for HIV, because we still dependent from donors. Donors fund about 75% of total prevention spending, and domestic budgets only 25%. And then just a few weeks ago, we heard that there will be a potential cut from global funds. So global fund funding may reduce 31 up to 46% for HIV program. And then we already know that funding from the US government is facing a significant decline. And the second risk we also identified during the program review, the regional budget, subnational budget, we identify 19% reduction in HIV/AIDS allocation. And the reason is because HIV is not included in the presidential priority program. So it's resulting in a decrease in a priority at the regional level. And until today, we're still waiting from the government approval for the HIV and also STI test, because we try to allocate about 7.5 million for the test kit. So if the government approves this proposal from the team of the HIV response, it will be target target testing for the 2026. And so if we talk about sustainability risks and key gaps, Indonesia still have high donor dependence, especially for outreach program, which is community health workers, and then prevention commodities, community-led monitoring, and also surveillance. We still dependent from donor, including the Global Fund. And then for the community health workers in HIV services and community service models do not yet have a regulatory basis, competency standards, or national, subnational financing schemes. So this is the situations that we already identified during our program review. So we have a significant gaps and challenge. So community systems are still overwhelmingly grant funded and weakly anchored in human resource, finance, and also information system. Point of care and community-based clinic lack clear transition plans to domestic budgets and are often seen as projects. HIV community health workers, including cadres, are structurally invisible in a human resources and financing system, leading to high risk of turnover and burnout. And about community-led monitoring models, we have a lot of models CLM in Indonesia, so still fragmented. And the CLM data are not yet systematically embedded in national information system or district planning or budgeting processes. And if you talk about social contracting is underused outside of pilot settings, and capacity gaps exist for both local government and also civil society organizations in designing and managing contracts. So this is our situation in Indonesia. So if we talk about integrating HIV services into primary healthcare, we try to put some recommendation to the government. So last week we had a meeting with our Vice Minister of in the Ministry of Health. So we push the government to institutionalize point of care and also community-based clinic as recognized community-based differentiated service delivery models in national and also subnational plans. And then we also put some recommendation regarding about community health workers. So we push the government to formally recognize community health workers in human resource and financing system, and also push the government to develop a national multi-disease community workforce framework. Because if you talk about integration, so we also need to identify the community health workers from other diseases as well. And then we try to harmonize and define a minimum CLM package and require districts to include a short response to CLM finding section in annual plans. And then we discuss about how to scale up social contracting, since it's not easy. And then if we talk about the corporate social responsibility, it's only episodic funding for the NGOs or CSO. So we try to push the government to scale up social contracting and also link the HIV Workplace Award criteria to concrete CSO partnership and also community contributions. So this is the result from the HIV Joint Program Review. So we already have a discussion with the Vice Ministry of Health, and hopefully that during the next 3 months after we heard the allocation from the Global Fund, we continue to push our recommendations to prioritize the engagement of the community health workers into HIV integrating system into the primary healthcare. Thank you, Inan.
Thank you, May. Thank you, May. And thank you for sharing and for highlighting the fact that the Grant Cycle 8 has actually started. The processes for Grant Cycle 8 has actually started, and this is one of the opportunities where the PLHIV networks can work with the program to actually push and advocate for PLHIV-led services. And thank you for highlighting the opportunities on getting support from corporations. However, CSRs are not as regular as we want it to be. It's episodic, so there are also challenges. Thank you so much for your points. We have heard from Uganda and we have heard from Indonesia. We only have like 5 or 6, 7 countries in this case study, and we acknowledge that there are different contexts per country, and we encourage everyone to also share how the integration advocacy is going in your country, or how you're engaging with the government in relation to integration. Now, before we proceed with our panel, we'd like to show you a video. Let's take some break and we will watch some video, and I'll hand this over to my colleague Emmanuel to share us some video.
From February and around March, we knew that people who are not presenting themselves to pick medicine, particularly young people and also people we call key populations. And we alerted NASCOP of the same. And because people who have advanced HIV disease, these are people who interrupt treatment, these are people who delay treatment, they need specialized care. NASCOP has now come up with the guidelines, and they have conducted online virtual trainings for all healthcare workers in Kenya, how to manage people with advanced HIV disease, making sure that they have access to CD4 count, have access to viral count testing machines, and then they are given feedback. Then they are supposed to go to facility more frequently than other people, so they can be staged when they are sick, depending on which condition you have, either cryptococcal meningitis, or whether you have bacterial infection, or whether you have typhoid. You can be requested to be going to a facility to more or less monthly or even weekly, and most of them have TB. So again, TB is given priority in terms of testing and even treatment before you are continued on ART. So that training has run from July to August, and we hope that now going forward, people with advanced HIV disease will be really very easy to find it easy to manage. We also, where we work here, we are supported by the global network of people living with HIV on the community side to monitor and make sure that people go to facilities so that we don't have people who are presenting with advanced HIV disease. The project we have is called the Last Mile under the Love Alliance program, and what we do is to follow up people who are on treatment so that they make sure that they adhere to treatment, they adhere to clinic appointments, and they take up what the health facilities are telling them. One of the reasons why we supported this integration is because people who have HIV, who are now living much longer in Kenya, are presenting with other non-communicable diseases, hypertension, diabetes, kidney problems. Some of these conditions come to you because you have that HIV. Some of these conditions come to you because of the treatment you have been in for 10 years, 15 years, or 20 years. So the most important thing is not just to look at HIV. This is not just an HIV program. It's supposed to be a holistic health program so that when people with HIV come in, they are screened for non-communicable diseases. They are also managed if they have, and they are sensitized on how do you prevent some of these conditions. However, because some of these people already have these conditions, we ask that as you give ARVs free of charge, you also help with this hypertension medicine, diabetes medicine, kidney problem medicine free of charge. And that is one of the latest campaigns we are running. We want HIV care to be under SHA. Once HIV care is under SHA, then the cost will not be a barrier for people who want to manage non-communicable diseases. And that is the benefit of integration, because we realize that once USAID left, the things that used to be free, including screenings and medicines for hypertension in some facilities, are now being charged. The hospitals are now introducing user fee, and we have many people who cannot afford. So we want SHA to cover HIV care, particularly on diagnostics, laboratories, and also non-communicable diseases.
We would like to call on Nelson, our colleague from Kenya. Nelson, are you there?
Yes, I'm here, and I hope
Yes,
I can be heard. And I hope here I can speak, unlike in the video.
Yes, we can hear you.
Thank you very much, and yeah, thank you very much. And sorry, at one point I got disrupted. It's raining where I am, but I hope people can hear me. And thank you to the GNP Plus for this convenience, because apart from what we share, we also learned, and we also know that we are not alone in this fight to respond to HIV and AIDS and sustain it and improve our health and well-being beyond 2030. Going by the questions that were being asked, yeah, I'll very quickly address that. But before that, let me say that the subject of integration in Kenya started way much before the Trump stop work order. In 2024 June, the Ministry of Health convened what we call national integration, some integration, and not other components like policy, budgets, and so on and so forth. And in that time, we developed as a country a roadmap and a work plan. But I think because we had plenty of resources from PEPFAR, USAID, and the Global Fund, it was never actioned. But operationally, the challenge was the HIV department within Ministry of Health had some significant changes. The head went, a new head came in, and so on and so forth. So the February stop work order came as a wake-up call, but the question was when, rather than if, the country was going to integrate HIV into general service delivery. And for your information, Kenya is joining the leagues of middle-income countries, and we don't really get consensual drugs in plenty like we used to do before with the Global Fund and PEPFAR. What we get is now development assistance, and that is also what has informed the government-to-government agreement that was signed, that I think we really are behind and supporting, and we are happy with that, because it makes the government take a responsibility. And I say so because even during the disruption in February, we in NEFAC and we as the community of people living with HIV, those affected by TB, we went to the Ministry of Health. We didn't go anywhere else. We didn't talk about America, we didn't talk about CDC and other NGOs, and we only went to the Ministry of Health and say it is your responsibility to provide care and prevention services to people who need it. And that is the dialogue that we've been having. After that, we were also incorporated into what we call technical working group for integration, and now this year we've walked a journey, and I hope in subsequent meetings we will be able to share. Kenya as what we call an advisory for the Ministry of Health, healthcare workers to integrate HIV care into routine health service delivery. And Kenya has developed, but is not yet launched, a blueprint, more or less giving around 4 components of how to handle HIV in the general health service delivery, including as non-communicable diseases among those who are established on treatment, those who are suppressed, and those who are doing well. But there are also special cases of critical and emergency in terms of those who have advanced HIV disease and children. So that be able to share in future if we have, and for our learning. We will also be happy to, because Kenya is now discussing having a regional integration summit, we'll be happy to talk to the Kenya Ministry of Health to find out if there may be a few of our colleagues from East Africa or maybe East Southern Africa can join, so that we also have that learning before we start talking about global pieces. But getting back to why we are here today with the disruptions, 3 significant areas were severely disrupted. One is human resources for healthcare workers. So we ended up with having commodities, medicines, but probably nobody or not adequate staff to dispense. But what I want to talk about is that USAID was supporting lower cadre healthcare workers, including mentor mothers who are women living with HIV, including adherence counselors, people who are experienced in HIV, and who are helping their colleagues and peer mentors. And these were disrupted. Even with the limited waiver, they didn't come back. So that means that there was a gap. But to respond to that, as NEFAC, we prepared our teams and we told them, where you can, please, and where feasible, support the Ministry of Health as a volunteer, because you are supporting for your own health, but also supporting your colleague as a peer, even if the payment is still not yet there. So that's part of the discussion, and a few of these lower cadre, the counselors, the peer mentors, the mentor mothers, some of them have been absorbed and incorporated into government. The other area that was disrupted was in laboratories. Apparently, the CD4 infrastructure collapsed with COVID, so they're working to reconstruct it so that advanced HIV disease is tackled. But viral load was purely being supported by the American government, and it's good that they came back with a limited waiver, but still other people missed. And that is an area that even we have gone to the Ministry of Health. We have even held a procession because we want laboratories to work, because that is a role that communities may not play, and including sample networking and sample transportation. But what is important is that we agree in the spirit of differentiated service delivery that for those who can, then they can go and collect results for their peers, so that the one healthcare worker in the laboratory is not dealing with a crowd, but one person who can go. For those who are suppressed, those who are not suppressed have to go to a facility to have a discussion with the clinician. The other area was on what we used to do, with the support of GNP Plus, we had just concluded a PLHIV stigma index, and with the PLHIV stigma index, the process is as important as the product, the report. And we were at the level of now developing an advocacy plan to follow that, also with the capacity building and dissemination of the report. That was basically Global Fund, but Global Fund, I think they were also following the cue from US government. So when they came up with the reprioritizing, and they narrowly defined what they call life-saving, all that work we do under stigma index. I think we're at the global level, maybe we still need to have the discussion. Our stigma is a barrier to uptake of commodities, because I think the understanding is that if you take to Kenya ARVs, people will pick it. But we end up with advanced HIV disease because ARV is available, people are not picking it. The reason being stigma. So that is an area that really suffered. The other point in terms of access and delivery of services, we managed because we pushed to make sure that we have different models of differentiated service delivery. Majority of Kenyan adults who are on HIV treatment are on what we call multi-month dispensing. So they're able to have their pills for 6 months, and a few of them are also in what we call fast track, where they have 4 to 5 months. And I think with that, then people are not crowding facilities. But during this time also, we worked with the Ministry of Health to make sure that the community ART groups are strengthened. And right now, Kenya is also rolling out community pharmacy model, where if you don't need to present in a facility, if you're actually suppressed, you are simply to collect a pill, you can go to a private pharmacy and pick it. And there you only show up in the clinic if you need your viral load done. And we also have agreed on how to relay reports if you are suppressed. So basically, that is how we have responded. On the side of stigma, we do a lot of virtual engagements and virtual meetings, and reach out to our peers where we can, and to make sure that people do not drop out of care. And the reason why we also want a community RT group, because other people may not want to present themselves at the moment where services are integrated, and a peer can go and then make sure that they have their medication, they are adhering well until things stabilize at a facility level. That is the same reason why we also support the community pharmacy model, because that is anonymous and it's a private clinic. Everybody is going there. It is not specific for HIV. Actually, people don't know that private pharmacies also dispense ARVs, and that then provides the anonymity and the privacy and confidentiality that some people want. So we are happy with that, and going forward, we are intensifying our engagement. And I like what Flavia said. We will always be here, whether government or who, but we think that in the end, you are going to have the Ministry of Health, care provider, and a person living with HIV, even beyond 2030. So we must get deep inside the government and make sure that we move there. The last point I wanted to share is that with the Kenyan signing of a US funding deal, they have been told now to develop an implementation plan for the first 1 year, and they've been given more or less like by January. And we just had a meeting when I came from ICASA, and what I said is that within their HRH plan, they must also have lower cadre. They must also specify the role of people living with HIV, supporting their peers to uptake to care. And they also must appreciate and understand that our advocacy role will continue, reminding them where services are not of good quality, but also appreciating where services are good quality. And fairly, they have that understanding. And I know a section of NGOs are not happy with that, but so far, I think the only bit that we agree with is that it is giving the government the responsibility, because it is the duty of the government to provide care for those who need it. And if tomorrow, next year, or before 2030, we miss these commodities, the person we call out is the Ministry of Health and the Kenya government. And that's why we work with them in this agreement. So thank you very much. And unless there's any specific question to follow up on, I would be happy to end it there and hope that now I can hear myself in the video.
Yeah.
Thank you.
Thank you. Thank you, Nathan. Before we go to the video, I'd like to call on Tariq, and thank you everyone for staying with us. We might have to extend for another 15 minutes to give chance to Tariq to share what's happening in Morocco. Tariq, the time is yours. Go ahead.
Thank you, Inad. Thank you, Inad. Thank you, JMP, for the opportunity that you are giving for people living HIV movement in the Middle East, North Africa, to connect with the global movement of people living with HIV. And really, I'm glad here to bring a perspective from the MENA region, but especially Morocco, because when we talk about integrating HIV into broader public health system, the realities are very different from one region to another. As you know, in the MENA region, HIV remains highly sensitive. It's surrounded by stigma, moral judgment, and by laws and social attitude that criminalize or marginalize the very people most affected. And that has a direct impact on how we advocate for meaningful people in HIV leadership. And one of the key of the challenges we face is visibility. HIV is often treated as a hidden issue. So when governments discuss integration or UHC reforms, people living with HIV voices are not naturally included, and we have to fight for that space every single time. At the same time, our people in HIV community history is different. It's different than South, for example, in South and Eastern Africa and many parts of the continent. The HIV movement was created and led by people living with HIV from day one. But in MENA, because of the low prevalence, the early response was led by doctors, medical specialists, and thematic NGOs. They did important work, but it also means that people living with HIV come later. So in fact, our people living with HIV movement only started to around 2010. And in a context where stigma and criminalization and limited civic space made visibility extremely difficult. So we're always talking about the low prevalence in the MENA region, but this is a very tricky expression because today the MENA region, if one of the highest new infections percentage with, according to UNAIDS, we are talking about plus 116%. And also when it comes to the 95% strategy, at the MENA region, only 66% of people living with HIV know their status. Only 56% of people living with HIV are on treatments, on IRT, and only 46% of people living with HIV are virally suppressed. Now back to the situation regarding the PEPFAR and the USAID. So with no PEPFAR or USAID support, MENA countries embraced integration out of necessity, but each country adopted it differently. For example, Morocco adopted the decentralization of IRT into primary health care. Tunisia kept a hospital-based model with slow PHC expansion. And Algeria maintained a strong medicalization, but with limited community recognition. Lebanon also, from its part, struggled to operationalize integration because of the economic collapse. And Jordani, for example, also linked HIV care to national insurance reform. So all these models were shaped by domestic realities and by how the Global Fund framed the priorities in each country. There is also another reality. When it happens, it's often symbolic, the inclusion. You might have one people living with HIV representative sitting in a meeting, but that person is not resourced, not protected, and sometimes not really listened to. In that situation, it becomes very difficult to influence policy or integration process. Of course, so now if we look at the Morocco's own integration journey, which has made a real progress in decentralization and integration of integrating IRT follow-up in primary healthcare. There are still important lessons we are learning about sustainability, because even outside the HIV service itself, people living with HIV continue to face direct or indirect forms of inclusion within the integrated system. And this, it often appears under other pretexts, very distant appointments, lack of available staff, or absence of necessary materials, and these barriers become even more severe when it comes to comorbidities and maternal health, where stigma can quickly shape decisions and access. So integration has advanced, yes, but the life experience of people living HIV in the broader health system still shows gap that we cannot ignore. So for me, the first critical element is financing. If people living HIV-led services are not funded in a predictable, multi-years way, they cannot survive inside an integrated system. And here I will give the example of Kenya Plus, which has the only support was from JP Plus, but there was a huge exclusion of national funds and global funds. So the people in HIV networks needs to be recognized as actual service providers with contracts, with resources, with stable roles inside the UHC implementation. And without that, the leadership becomes only symbolic. The second thing is the policy frameworks. We need people living with HIV leadership to be writing into national policies, technical working groups, accountability mechanism, and strategic plans, not only as consultation, but as part of governance structure. Because when is it in the policy, it becomes much harder to remove, even if political context shift or change. Another thing that I would like to highlight, which is fundamental, is the rights and protection. An integrated system cannot function when people are still afraid of stigma and discrimination. We need a legal protections for people living HIV, and the key population must be clear, enforced, and monitored. Otherwise, again, the integration remains only a theory on paper and not lived in the reality. So I believe that there is also another strategy that can be crucial, especially in Morocco, is investing in community system, not just clinics. Integration tends to focus on the health facility, but people living HIV-led services live in the community. For example, peer navigation, psychosocial support, legal assistance, community data collection. This service must be part of the national health package for integration to be truly effective. To conclude, I think in Morocco and across the region, the sustainability of our work depends on alliance. And we as people living with HIV, we can't work or stand alone. We need the strength of the key population movements, the women's rights groups, the disability movement, and the migrants group. And here I would like to highlight that the movement might be at national level, it's a bit weak, but if we say the regional movement, we can be proud. And here I see that Tallinn from Mina Rosa is present. We do have the MENAPOD, the network of people who inject drugs. So I think that it's very crucial that we as people living with HIV connect with the others and with the other key population. I think we are we are passing already the time, but let me just to conclude. Maybe we are not facing the challenge of integration in the MENA region and in Morocco, but I would like really to highlight that the integration is not a magic solution. It does not automatically improve HIV services, and it does not automatically include communities. But when people living with HIV are truly leading, not invited only symbolically, integrations becomes an opportunity for justice, dignity, and for sustainability. Thank you.
Thank you so much, Rick. Thank you for highlighting the human rights, that there's no successful integration if people are still scared of stigma and discrimination. And of course, the reality of integration, that it's not a one-time solution for an effective HIV response. So thank you so much. Thank you so much, everyone, for staying with us. I'm gonna play the video. After we play the video, yeah, so let me oh no, I cannot share the sound.
We can share
Anyways.
it tomorrow as we share the report.
Yeah, we will share the video with you later. I cannot share it. I cannot share the sound. Thank you so much, everyone. Florence, would you like to say something as we end?
I feel like I don't know whether it's me whose calendar gets marked wrong. We still have some 20 minutes on the call. So I don't know if there are any quick reactions. I think Albertina is on the call from Eswatini. She's also joined us and covered her experiences in the case studies report. Maybe just 2 reflections, and then I'm happy to come in at closing. Any reflections from the floor? Any other country that wants to share anything? Yeah. Albertina
has dropped out.
I see Albertina on the call. I don't know if we can allow her to speak. Helena?
Yeah.
It's done.
Yes, let me try to unlock.
Hi, Albertina. Can you be able to speak?
Yes, I'm here.
Please go ahead. Any reflections from your end? You also did participate in the case studies report coming out tomorrow.
Okay, thank you so much, GNP Plus and the colleagues. Eswatini, as we all know, has the highest HIV burden with an adult prevalence of 24.8%, which is a decrease from the 27%. And then we also have 220,000 adults living with HIV and 0.62 annual incidents among adults, which means we have 4,000 new infections per year. And women are disproportionately affected by HIV, with 28% of adult women living with HIV compared to the 18% men. And then adolescent girls and young women aged 15 to 24 years remain at high risk of HIV. And then in terms of integration, I would say for us at Eswatini, we got an invitation early last year from the Ministry of Health to be part of the meeting. And then some of us were selected to be in the core team, which will be doing the work on integration. I was amongst those who were on the core team, and then we did engage because we were trying to, we were sensitized on the integration, and then we engaged. We're also part of the team which then came out with developing the ICTM framework. And then also communities were sensitized, although I would say not many the numbers were few because it was like there was no funding for the sensitization. And then we're also trained on being trainers of ICTM or on the integration, whereby we could, when we have maybe time, or just go out there and train other people on the integration. And then also I would add that Eswatini has rolled out LEARN, has recently rolled out LEARN in certain areas. And what we have noted was that the rollout has happened in the rural area, mostly in the rural areas. The challenges that we had with that, there was no support to attend the meetings. There was a lot of meetings that were being held, such that some of my colleagues, they dropped out because they couldn't attend, they couldn't continue attending. So now I think it was 2 of us that were left there. And then also, we were discussing the integration into the clinic, of which we do into the health sector, and of which we do agree with that. But we also felt like there were issues that were outside outside the health center, like the work that we've been doing. It was like no one was talking about issues of advocacy and other issues related to the integration, because yes, we can integrate, but still there's some activities that needs to be done by communities. So we felt like issues outside health sector, such as advocacy, were not planned for. And then also, due to lack of funds, not many communities were reached for sensitization. Only a few were reached. What we would like to see is that we would like to ensure that there is funding for PLHIV-led organizations, so that we can be able to do the community-driven initiatives. Like I even talked about that now we're rolling out LEARN, and there has not been much sensitization on LEARN. So as people living with HIV, we still feel like it would be nice for us to have maybe some sort of funding that will help us to go out there and sensitize communities on LEARN. And then also we feel like they still need to educate our Ministry of Health and also the NACs on issues of community engagement, because community engagement is still an issue here in Eswatini. Okay, we also feel like there should be promotion of social contracting.
Hi, Albertina, just your final point because of time.
Okay, my final point was, I was already on the final point, which was like we need to promote social contracting, so that to ensure the involvement of people in HIV in implementation. But my last point would be that as a network, we are trying so much to come together and work. We still need GNP Plus to visit. We're still waiting for GNP Plus to come and visit us in Eswatini. Thank you so much.
We owe Eswatini a visit. Thank you so much, Albertina, for sharing. And we would like to acknowledge Abdul on the as part of our participants from Nigeria, who also took part in the case studies. I'd like to read some comments in the chat box from Patricia. One thing from her, the models we have should focus on person-centered treatment and move away for disease-focused treatment. That way we have our integration. Thank you so much. Flavia, I'm gonna hand over now to Florence. Flavia, if we don't have time anymore, so you can just chat if you have time to chat.
I was in a busy place. I want to say thank you, and also to say that social contracting is the way to go, and social enterprise for health, because with the cuts, we need to now talk business in health. Thank you. Bye.
Thank you, Flavia. Thank you. Florence,
thank you,
over
Flavia.
to you.
Thank you, Ina. Thank you, everyone who's participated. I think every time we come to these calls, we at GNP Plus are challenged to go and think. Now we have to figure out social contracting and social enterprising for health. I have had the opportunity of talking with some of you and hearing your exciting ideas about how you want to do businesses for health with your organizations for sustainability. And those are some of the things we will take into our advocacy and into our planning next year. Mine is to say thank you. Thank you, because since January, last week of January, we have been convening here every other 2 weeks. Whenever we didn't convene here, it was because we were convening in person. Many of you have come here, shared what you know, shared your fears, shared your frustrations, shared your lessons. We have built a community. We have strengthened what was an impactful community that I believe We must all acknowledge grew complacent. We were assured our treatment will be there. We were assured of the advocacy processes. Rock up and do the PEPFAR process every year, rock up every 3 years and do national applications to the Global Fund, and then go back to do every other thing that we do except make the visibility and the issues of people living with HIV stand up boldly, and stand up centrally to where they needed to be within the HIV response. But I love how we quickly stepped up, we quickly ran around, we quickly became, I don't think many of the leaders in this call have even had a moment to process what has happened the whole year. We've just been on the go responding. As we close this 17th convening, I thank all our partners who have made it possible to do this work online, offline, AIDS funds through our Love Alliance grant, VIV Healthcare, Gilead, World Council of Churches, who am I forgetting? Global Fund, and many others. All the facets of work we have done this year has been because of partners who have reached out to support us. UNAIDS technically guiding our discussions around integration. Annie was here in the call. I've seen Clarice from WHO also here, the HIV treatment team. We've not been working alone, even though some people made it into the call, some people did not. We have noted that every time we come together to talk our treatment, we have the highest number. We had the highest number today, I think rocking about 96, 97. We had about 80 people when we joined here to talk about the dissemination of the WHO guidelines sometime in October. And we had about 120 plus people when we did our inaugural PLHIV-led HIV cure advocacy webinar 2 or 3 weeks ago. So we are sort of getting a sense of what it is you want us to be coming here to talk about. And we will take all of that into consideration. Inad is smiling because he knows the work is cut out for him next year. Thank you. Thank you so much. I hope as we rush to do end of year deadlines and as we close with optimism, proud of what we've been able to accomplish. We are here. None of us thought we would be here in January, but we've gotten to the end of the year and we've gotten here stronger, leading, powerful, visible. Let's rest. Let's think about how to come back here. The work with the integration report is just finished. We have identified the asks. Next year, we must come together and mobilize to go get those asks given to us. Thanks to the consultants who've worked with us, Dr. Mumbi, who's not here today, Dr. Patricia, thank you. Thank you to Edith. You've all managed to take what we've said and kept it in our language. We are so appreciative of that. And thank you to everyone else. Thank you to the GNP Plus team who works tirelessly. Thank you to Orals, East Africa Media, who have managed to deal with our last-minute requests for last-minute deadlines and made us look so good communications-wise and visibility-wise. We are the people living with HIV leaders now. We are the people living with HIV leaders now. We are the people living with HIV leaders now. Thank you very much.
Thank you so much. This will be the last convening for this year. We will be again convening next year. We have a lot of, we have a number of convenings prepared for you. We will bring you U equals U University next year as well. We have taken all your input. So thank you so much. Have a nice end of the year and we will see you in January. Bye-bye. Thank you, everyone.
Thank you, everyone. Bye.